Okay. Right. Okay. So let's make a start on respiratory medicine. Right. So today's focus is on obstructive and restrictive lung disease. Right. But I've shared all the papers with you, and also that note. That's ultimately going to go into a book, but that's fine. You can use it. No problem. Hari, ඒකත් බලන්න ඒකෙත් තියෙනවා related stuff, right? Okay. Fine. Okay, now a key categorization of respiratory disorders is made based on the FEV1 FVC ratio on spirometry. And this is into obstructive airways disease and restrictive airways disease, right? So I've given you a list of all the causes of obstructive and restrictive airways disease on the right side of the slide. So please familiarize yourself with these. Remember that restrictive lung disease doesn't only mean lung tissue related problems. Anything else also that causes restriction of lung inflation, like chest wall abnormalities or neuromuscular disorders, can also be classified under restrictive lung diseases. Right. Okay, so let's start off with asthma. Right. Let's start off with asthma. Right. Now this first MCQ is sort of focusing on causes, etiology, etc. Right. The first thing is that asthma is a disorder of the small airways, and there is reversible airflow obstruction. And we'll come to the diagnostic criteria in a minute. But all of you should know that there is reversible airway obstruction. And when we did a long case of a patient with shortness of breath during the professorial appointment, we showed that this reversibility of the airflow obstruction, how that translates into the clinical picture, right? Hari. Now, looking at the pathogenesis of asthma, right? Now, the pathogenesis of asthma is not exclusively IgE and eosinophil mediated. Of course, there is a subset of patients with asthma who have this IgE, eosinophil, mast cell sort of story. But there are, as you can see in this, there are lots of other mechanisms, and these are called endotypes, right, of asthma. Right? There are various different mechanisms of asthma, right? So these are called endotypes and phenotypes. And there are several. Right? Some of them are eosinophil mediated, right? Like allergic asthma. Some people get this late onset eosinophilic asthma, right? Aspirin exacerbated asthma is also eosinophil driven. So there are some eosinophil mediated asthmas around. But remember that there are also asthma where you have a predominant neutrophil response, right? As well. Right? So you don't have to know these in detail. This is a bit advanced for you at an undergraduate level. But the point I'm trying to make is that you've been taught that asthma is eosinophil IgE mediated, but that is not always the case. There are non-IgE eosinophil mediated disorders, for example, like neutrophilic asthma as well, right? So that is the point that you need to remember. You don't have to remember all these various subtypes, right? So it's not exclusively IgE mediated, but yes, the second statement is not saying everything. You can see an increase in airway eosinophils and mast cells in asthma. That's true. But it is not exclusively the case. Right? So let me just put a pointer on so that I can mark as we go. So exclusively කියන වචන නිසා පළවෙනි එක වැරදි. But second is not committing. එහෙම ලොකුවට commission එකක් නැහැ. නිකම්ම airway eosinophil mast cells වැඩි වෙනවා. Right? හරි. Third statement is right. Hari. Okay. Now, the next thing to remember is we now recognize that there are certain factors that increase or make asthma worse. Right. One of the classical things we now recognize is reflux එක MCQ point එකක් විදිහට මතක තියාගන්න. Gastroesophageal reflux disease, right, is a well-known precipitant or trigger. Makes asthma worse. We also know that this dust mite, right, dust mite also is a very famous thing that makes asthma worse, right? And so is allergic bronchopulmonary aspergillosis, right? That is also known to cause worsening asthma, right? So that is true. Allergic bronchopulmonary aspergillosis can also cause a sort of local region of bronchiectasis in the chest as well. So එකත් මතක තියාගන්න as a point. Allergic bronchopulmonary aspergillosis can cause sort of localized bronchiectasis picture as well. Hari. Now, a few important MCQ points about some of these asthma syndromes. So I told that asthma, these are called endotypes and phenotypes. So this is the classical allergic asthma that you see in children, right? Classical allergic asthma that you see in children. Exercise-induced asthma is obviously brought on by exercise, right? That you know. But there are various other things that you see, like late onset asthma in adults. That's a eosinophilic asthma. Aspirin-related asthma, right? So these are all sort of various asthma syndromes. All of these have a sort of IgE-mediated pathogenesis in all of these types. Right. So late onset eosinophilic asthma, two important things to remember, right? Some of them are resistant to steroids, and they are associated with chronic rhinosinusitis and nasal polyps. Aspirin-induced asthma is also associated with nasal polyps, right? So this is just factual information that might appear in MCQs. එක අහලා තිබ්බ මං හිතන්නේ පස්වෙනි එකේ එක හරි නේ. Aspirin-induced asthma is associated with nasal polyps. Right, so that is true. Right. Okay, so we know now that not all asthma is eosinophil IgE, and we have talked about few of the triggers, precipitants, and so on. Right. Any questions about that? Hi. Stable asthma කියන්නේ patient stable asthma. The patient doesn't have any or very minimal symptoms, but it suddenly causes worsening. That's what it means, right? Doesn't have a special meaning there. Okay, good. Let's move on. Right. Now, this is an easy question. It's just trying to compare your ability to diagnose asthma versus other disorders that have a similar presentation. And obviously, if you have done the clinical thing properly, this is easy. Exacerbation of these following exercise is suggestive of exercise-induced asthma, right? So it says suggestive, right? Suggestive කියන්නේ ළඟින් ගියත් ඇති. We know that a gallop rhythm is seen in heart failure, and that is definitely not asthma, right? Gallop rhythm. Diurnal variation of symptoms is suggestive of asthma. Remember, because of the complete airflow obstruction, which is reversible airflow obstruction. And we know that this changes with the time of the day, right? Diurnal variations, that's asthma. Eka hari. History of atopic dermatitis. Yes, patients with those eosinophilic asthma, right? The allergic asthma or late onset eosinophilic asthma, they have other allergic manifestations like atopic dermatitis, sinusitis, those sort of things, right? They can have. Last one is wrong. You know that bilateral inspiratory crackles are a feature of interstitial lung disease, not of asthma. Bilateral inspiratory crackles can also occur in heart failure, pulmonary edema. So these are very basic clinical stuff which are easy. So this question is easy. You just have to remember your clinical stuff. Again, I emphasize that. Clinical tika dannawa nan, you can answer lots of these MCQs without a problem. right? So that is easy.
Sir, cardiac asthma is not asthma කියලා.
Yes, cardiac asthma is not asthma. That is heart failure manifesting like asthma. Yeah, that you call cardiac asthma. No, so statement 1, shortness of breath versus exertion නෙවෙයි මෙතන කියන්නේ exacerbation of these following exercise කියන එක තමයි. So that's more suggestive of exercise induced asthma, right? Mostly. ඒ කියන්නේ මගේ suggestive කියන වචනේ නිකන් loose thing. It's not a strong thing. It's suggestive, right? It's not confirmatory, right? So you can take it as true. Right. So coming back to how you actually diagnose asthma, the clinical features are very important, of course, but you have to back this up with investigations. And lung function tests, right? The spirometry is a standard, right? That's an absolute standard of diagnosis. And I've given you the criteria. So you have to have a low FEV1 FVC ratio with reversibility, with evidence of reversibility. Evidence of reversibility. You also couple this up with, if possible, with CTFR measurements, peak expiratory flow rate measurements. ඒකෙත් ලස්සනට බලන්න පුළුවන් if you can serially measure the peak flow, that diurnal variation you can see, right, quite nicely. So that coupled with a obstructive pattern on FEV1 FVC with reversibility as defined in this slide you can see, 12% rise in FEV1 and or a 200 ml increase in FVC after bronchodilate. That is that. So all of that together helps you to establish a diagnosis of asthma. In some countries, we also use this FeNO කියන එක, that's fractional excretion of nitric oxide, that can be used, that is increased in asthma, used for the diagnosis as well as monitoring of response, monitoring of treatment. We don't do this in Sri Lanka, at least not commonly, but in other countries like the UK, for example, used for diagnosis and monitoring of response to treatment. Fractional excretion of nitric oxide. So ගායනී අහලා තියෙනවා asthma, cardiac asthma, bronchi, yes. So that's in heart failure, it sometimes presents exactly like asthma with bronchi. So they can get bronchi, yes. Hi. So this is just a little bit of FVC එක නෙමෙයි මේ බුද්ධිනේ FV1 FVC ratio එක තමයි අඩු වෙන්නේ. Right? Sorry if I said FVC, it's FV1 FVC ratio. මෙතන sorry මේකේ sorry. So මෙතන වැරදි මම මේක ලියලා තියෙනවා. So 12% increase in the FV1 FVC ratio or a 200 ml increase in the FEV1. Sorry. මේක වැරදි මම මෙතන ලියලා තියෙනවා. Right? Okay. Right. So, right. Now going on to acute severe asthma. Sorry. Acute severe asthma, you have to know the diagnostic criteria. Make it. Sorry. You have to know the diagnostic criteria. So there are 4 important diagnostic criteria for acute severe asthma. You can see it in the slide. The peak flow, best or predicted, varying 33 to 50%. Respiratory rate more than 25. Heart rate more than 110. But again, in your appointment, I told you, inability to complete sentences in one breath is a good bedside test for acute severe asthma. Right. So peak flow, එක වැරදි, 33 to 50%. This is something I told you during the appointment. What about this normal CO2 business? So an important thing always remember is that, this is a very important point, CO2 එක ළමයි normal නම්, that indicates life-threatening asthma. Right. What is the reason for that? That's funny, neda? Because normal PCO2, how can that indicate life-threatening asthma? Right. In asthma, usually, you know that the person hyperventilates. When the person hyperventilates as a response to the bronchoconstriction, they are able to wash off the carbon dioxide very nicely. Ne? Pata gala okay eliyata දාගන්න පුළුවන් carbon dioxide එක ලස්සනට එළියට දාගන්න පුළුවන්. Able to wash off the carbon dioxide. Carbon dioxide is a beautifully water soluble gas. ටක් ගාලා එළියට යනවා, wash out වෙනවා. So in a patient with acute severe asthma, their CO2 is low because they are nicely washing it off. Because of the hyperventilation, they are washing off their carbon dioxide. හැබැයි, when the patient gets exhausted, now it's life-threatening stage එකට යනකොට, patient exhausted වෙනවා, හුස්ම ගන්න බෑ, the CO2 starts going up. So even a normal CO2 is dangerous and that is life-threatening. So සාමාන්‍යයෙන් අඩු වෙන්න ඕනේ. If it's being washing off normally, it should go down. So normal CO2 is in risky territory. It means that the CO2 is starting to accumulate. And that is life-threatening asthma. Of course, if the CO2 is high, that is near fatal asthma. Raised PCO2 is near fatal asthma. Right. So make a definitely වැරදි. Definitely වැරදි. Right. Then there are other features of life-threatening asthma, as you know, like silent chest, right? And of course, they can get altered consciousness, cardiovascular collapse as well, like hypotension or arrhythmias, right? But remember that CO2 business, එක නිතරම MCQ වලට අහන කාරණයක්, so you need to remember that. Silent chest indicates clinical improvement is absolutely rubbish. That is wrong, right? That is life-threatening asthma. Right. Now, how do you manage acute severe asthma, right? Mainly, we've talked about this before in your appointments, oxygen-driven nebulization, steroids, and magnesium sulfate in patients who don't respond to nebulizers and steroids, right? Magnesium sulfate. Remember that controlled oxygen කතාවක් නෑ මෙතන. That is in COPD, patients who have CO2 retention. එක බොරු. Remember that IV aminophylline is not first-line therapy. Not first-line therapy. It can be used if the patient is not responding to any damn thing. You can use it. Try it. But it is definitely not recommended as first-line therapy. Not recommended. Sorry? Not recommended. It's used in very bad sort of patients who don't respond to anything else. The reason for not using this is important as an MCQ point is that the risk of toxicity with aminophylline is very high, right? And it can cause two things. Remember, hypokalemia is very common with aminophylline infusions, and arrhythmias. Arrhythmias are very, very common, right? So toxicity, arrhythmias, those are very common. Kanchana, when you do a chest X-ray, if your patient is not responding to your initial therapy like steroids, nebulizers, then you would do a chest X-ray, and that is to look for a pneumothorax, right? Okay, so that is about acute severe asthma. And remember, life-threatening asthma features you need to know. Of course, if the patient has life-threatening asthma, they will probably need intubation or ICU care, right? So that is important to remember as well. Right. Okay. Now the next MCQ is discussing on long-term management of asthma. Now, the long-term management of asthma has changed, right? And I will tell you the change, right? Right. Now, we still follow a stepwise approach in the long-term management of asthma, but the main change now, which you have to know, is that we no longer recommend short-acting beta agonists as single therapy. So, අපි අර ඉස්සර කිව්වනේ mild intermittent asthma වල you can give SABA, short-acting beta agonists like salbutamol on a as required basis or as needed basis. Current guidelines do not recommend this anymore. And there's a lot of evidence which I don't want to go into why that is the case. Currently, the recommendation is even in mild asthma, symptoms less than twice a month, to use this ICS formoterol combination. ICS formoterol combination. It's a ICS LABA combination, but a special one because it has a MART කියලා ඔකට කියනවා. MART, maintenance and reliever therapy. MART, MART. So it can be used as a reliever medication as well as a preventer medication. MART therapy is called MART therapy. MART, MART. So as needed ICS formoterol combination. Or the oka නැත්තම් ඔය inhale එක නැත්තම් still if you are taking a SABA, have to take a low dose ICS with the SABA. SABA එක ගන්නකොට low dose ICS එකකුත් ගන්න කියලා තමයි කියන්නේ. Right? So that is the recommendation. Right? That is the recommendation. Okay. Hari. Any questions about that? So that is very important to remember. So no longer do we recommend a SABA as a sole intermittent therapy. Right? So it is taken as a sort of the preferred thing is to do that as a ICS formoterol combination as needed. Or when they're taking a salbutamol, take an ICS as well with that. Right. Okay. Right. And then, of course, the other steps, what you're doing is the focus is on ICS LABA. As you go up, you increase the dose of the ICS LABA. Hari. ගොඩක් අය එකපාරට disconnect වුණා. I don't know why. Right. Light කපලත් ගන්න. Sorry. So, Taradini, good question.
So, මම හිතන්නේ මේ පැත්තකට වහිනා මේ
වහිනවා කෙලිය. ඔව්. හරි. Okay. So, ICS LABA එක ඒකේ දැන් there is a good question that Taradini is asking, does it cause immediate? So that's why Taradini ඒක special ටිකක්. This ICS formoterol combination is a bit special because it has a acute onset of action as well. ඒ කියන්නේ ඒක MART කියලා කියන්නේ maintain and reliever therapy. So එක ගලින් කුරුල්ලෝ දෙන්නෙක් මරා ගන්න පුළුවන්. It is a special type of inhale, right? This combination has a immediate effect as well as a long term effect, right? ඒකයි. හරිද? That's a good question. So the big difference is this: the SABA is going out of the window, right? Nimesh Altina, intubation NIV, that's a slightly different thing. It's ICU level decision. NIV දෙන වෙලාවල් තියෙනවා, intubate කරන වෙලාවලුත් තියෙනවා. ඒක it's a little bit of a different thing. හරි. Difficult thing to decide. So you can see in the as you go on, ICS ලාභ තමයි දිගටම ඕකේ යන්නේ in the long term management. හරි. Okay. Right. So let's go to the MCQ now. Fractional NO levels are used for monitoring clinical response. Yes, right? Not in Sri Lanka, but in other countries. And let's get this out of the way. Leukotriene receptor blockers වෙන්න ඕනේ. Leukotrienes නෙවෙයි. Please make leukotriene receptor blockers. Right? Like montelukast are used in two settings. Aspirin-induced asthma, right? And also in exercise-induced asthma. They are effective in those two settings. And also in some patients with long-term chronic asthma, සමහර වෙලාවට පාවිච්චි කරනවා. But currently ළමයි, මෙතන main thing is because there are some adverse effects that people are describing. හරි? With these drugs. එතකොට හැබැයි අපි aspirin-induced asthma වල there is a benefit as well as in exercise-induced asthma there is a benefit. But in the other types of asthma, වැඩිය ලොකු සෙල්ලමන්නේ ඒක නිකන් other options, second line options වලට තමයි ඕක එන්නේ. හරි? ලොකුවට දෙන්නේ නැහැ. Right. Currently, the main option is the ICS formoterol, which is a special thing, both acute action, long-term action. That sort of foundation of care, but then you increase that ICS LABA sort of combination. තමයි දිගටම අපි පාවිච්චි කරන්නේ. හරි. Okay, good. Right. හරි. LABAs are first-line maintenance therapy in patients with chronic asthma. හරිද වැරදිද? ඒකට කලින් 4 හරිනේ. අපි 4 දන්නවා. Combination therapy LABA ICS ඒක හරි. Right. Third statement is false because whenever you use in asthma මෙතන කවදාකවත් LABA එකක් විතරක් පාවිච්චි කරන්නේ නැහැ ළමයි. Right? It's always ICS LABA combination එක දෙක එකට යන්නේ, right? We don't use a LABA alone in long-term asthma management. Hari. Supun in exercise. So leukotriene receptor agonist is first line, possibly yes. You can use them in exercise-induced asthma and aspirin-induced asthma. So they are first line drugs. Kela gattat kaman yes. So Montelukast can there are some side effects of Montelukast which have been recently reported, right? Okay, any questions?
Excuse me, sir.
Yeah.
Sir, in one of our pediatric sessions with Ranganathan madam, she said not to even prescribe Montelukast.
එහෙම නෑ. එච්චර දුරකට යන්නේ නැහැ. හරිද? But you have, there are warnings, right? There are warnings.
Okay, sir. Thanks.
හරි. ඒක prescribe කරන්නේවත් නැහැ කියලා එකක් කියන්න බෑ. That is not true. හරි. Right. Any other questions? Right. Hi. After exacerbation, how do you start inhalers? It's a complicated situation. There is no special protocol, but you have to use a lot of sort of things to decide that. ICS formoterol Lanka with government sector again. Other options, leukotriene receptor antagonist the exercise-induced asthma, there are various other things that we do. You can use inhalers like you do normal people, no problem. Leukotriene receptor blockers are used in exercise-induced asthma as well. Right? Any other questions?
Sir, in this fourth one, I'm not sure if I'm thinking this here, it is LABA plus ICS. But guideline is specific to formoterol.
Even LABA and ICS can be used to combine LABA and ICS. It has to be specifically that drug, but you can take that as true. Right. Okay. Any other ones?
So in exercise-induced asthma, how is there a time period that we prescribe the patient? This must before the exercise you have to
drug. Right? They can be put on the long-term leukotriene receptor blockers. Or samhara me guidelines පොඩ්ඩක් වෙනස් වෙනවා. ඇමරිකාවල තියෙන විදිය නෙවෙයි මෙහෙ තියෙන්නේ. පොඩි වෙනසක් තියෙනවා. හරිද? But you can use inhalers before the thing. For example, you can use ICS formoterol before exercise, about half an hour, 15 minutes before exercise. ඒ වගේ කරන්න පුළුවන්. හරි? There are lots of options. හරි? Right. Okay. Now, there are a group of patients that don't respond to any damn thing. And if they have eosinophil related, IgE mediated disease, you can use the monoclonal antibodies against IgE for managing them. Hari? Right. Okay. Hari. So that is again in selected patients who have very severe disease that don't respond to anything, but they have to have an IgE related mechanism, of course. Hari? Right. මේ අර රංගනාഥන් මැඩ එපාක්කු එක පීඩියාට්‍රික් වල වෙන්න පුළුවන් හැබැයි ඔබ ලෝක වැරදියට මතක තියාගන්න පීඩියාට්‍රික් වල දෙන්නේ නැහැ because of the problems I showed you. ඒකද දන්නේ නැහැ කිව්වේ.
Yes, it was told in the pediatric section.
ඒක හරි. That is right නේ. මේකද මේ බලන්න මේ මම මේක දැම්මනේ මේ. So this is pediatric වල දෙන්නේ නැති එක ඇත්ත. Right? Because of the but adults we do use them. හරි? එහෙම ප්‍රශ්නයක් නැහැ.
Okay, thank you.
Right. Now, with that knowledge, you can answer this question easily. So here, whatever it is, we don't use steroids alone currently. Right? So whatever it is you are using, you have to add a LABA onto this. Right? The best response MCQ, the symptoms are going on, blah, blah, blah. You're not surprised that they are going on because it's just steroids, patient. So current guidelines, you have to use a combination of LABA and ICS, right? So adding in a LABA is the best thing to do here, right? So take a salmeterol, beclomethasone combination එකක් පුළුවන් පාවිච්චි කරන්න. Right. Good. Right. Any questions about asthma lamai? So remember the guideline has changed. Remember this ICS formoterol combination, which is called a MART drug, right? So maintenance and reliever therapy. Right. Okay. Right. So if you're happy, shall we go to COPD if there are no questions? Any other question? Right. Okay. I'm looking at the chat also, but there aren't any questions. Right. Okay. Right. Now COPD, right, is a sort of umbrella term for two main disorders, right? So two main disorders under that umbrella term. The two main disorders are emphysema and chronic bronchitis. Emphysema and chronic bronchitis. Right? So these are the sort of disorders included under that umbrella term, right? In emphysema, there is small airway disease and sort of dilatation of the distal air passages. So there's small airway disease, dilatation of the distal air passages, right? That is what you see in emphysema. In chronic bronchitis, they get recurrent sort of bronchial inflammation, infections, chronic bronchitis. So these are the disorders that you include under that big term of COPD, right? Right. So this is what you see, right? So on the emphysema, there is a small airways, bronchiolar problems with destruction of the distal air passages, and you have another entity which is chronic bronchitis, which you have recurrent bronchial infection and inflammation, right? And there is cough, sputum, infection, right? Hi. COPD can occur as a manifestation of alpha-1 antitrypsin deficiency. That is true, right? That is true. And this can also cause cirrhosis, right? Rare genetic disorder causes emphysema and cirrhosis. Because alpha-1 antitrypsin is one of these things that balance the breakdown of alveoli, the sort of matrix eva. So that is why the deficiency causes emphysema. Irreversible dilatation of the air passages proximal to the terminal bronchiole distal emphysema wala thiyene distal destruction and dilatation. So the word proximal here is wrong. It has to be distal disease. Distal eliyata. So small airways, terminal bronchioles, alveoli ehata tamai prashne matuwenne, right? So that is what you see. Right. Now actually you can describe the clinical syndromes of COPD, emphysema, chronic bronchitis. You can sort of define the clinical syndromes, right? Patients who have predominant emphysema are called pink puffers, and patients who have predominant chronic bronchitis are called blue bloaters. Now, in a practical sense, we don't actually see these blue bloater, pink puffer in actual practice because it's always a mix of these things. But it helps to understand the sort of pathology or pathogenesis of COPD when you divide it like this. Right. What is very important to remember is this. In emphysema, right, there is significant tissue destruction distal to the terminal bronchiole. So tissue destruction. Okay, alveolar wall there is a small airway disease as well with the alveolar wall problem. Alveolar wall problem. Hari dekama tiyenawa. Then what happens is you have the ventilation going down because the airway problem, the ventilation is not good. Plus, because the alveolar wall is destroyed, there is perfusion problem as well. Dekama tiyenawa. Ventilation is poor and the perfusion is also poor. So ultimately there is a matched VQ problem. Ventilation uttadu, perfusion uttadu. Right. Okay. Right. Now in chronic bronchitis, right, again it's mostly a little bit more proximal airways problem. But the alveoli are normal. Alveoli wala prasnayak naha. Alveoli wala problem ekak naha. There is no alveolar issue. So there the ventilation, there is a significant ventilation perfusion mismatch in chronic bronchitis. Right? So chronic bronchitis, large airways and the sort of bigger bronchioles are affected. So the ventilation is on the tamadui. The ventilation is significantly affected. But the perfusion is okay because the alveolar walls are okay. Right? But because of this, there is a significant imbalance between the ventilation and perfusion, which causes severe hypoxia and then leads to pulmonary hypertension and heart failure. And that's why this blue bloater story comes into play. Right? There is more profound hypoxia and heart failure in these patients. So this is sort of the syndromes that you see in emphysema and chronic bronchitis. So emphysema, because the alveolar wall is also destroyed, both the ventilation perfusion is abnormal. But in chronic bronchitis, the ventilation is low, but the perfusion is good. So that causes significant VQ mismatch. All right. Okay. So let's go back to this now. COPD, can it give rise to a reduction in the DLCO? So DLCO measures the diffusion of gas across the alveolar capillary membrane. In emphysema, this alveolar wall is destroyed. So in emphysema, you can have a reduced DLCO. Right? Because in emphysema, the alveolar wall is dilated, destroyed, everything, the alveolar capillary membrane, so you get a reduction in the DLCO in emphysema. Right. A severe ventilation perfusion mismatch is seen in patients with emphysema. Emphysema wala both are low. Ventilation, perfusion, both will be low. Right. But in bronchitis, the ventilation is affected, but the perfusion is intact because alveoli walls are intact. So you get a significant mismatch between ventilation and perfusion, which gives rise to hypoxia. Right. Now, a main problem in COPD, as obviously you know by now, is that they get recurrent infections. So the clinical stories where they usually come with recurrent infective exacerbations. And in patients who have recurrent of these exacerbations can be due to Pseudomonas colonization. Right? So Pseudomonas colonization can present with recurrent invective exacerbations is true. Right? Pseudomonas COPD වල විතරක් නෙවෙයි, we see in other chronic respiratory diseases like bronchiectasis, for example. හරි? ඒකෙත් අපි දකිනවා මේ ප්‍රශ්නේ. Right? Pseudomonas infection. Right. And that is why people who have recurrent bad exacerbations, we sometimes treat them with something like ceftazidime to cover the Pseudomonas. Right. Okay. Any questions about that MCQ? ඒ ගැන මොන හරි ප්‍රශ්න තියෙනවද ළමයි? Okay. Right. So let's move on to the next one. Right. Now, the question number 6 is focusing on infective exacerbation of COPD. Again, if you remember what I taught you during the proper minor, this is just a piece of cake. හරිම ලේසි. Right. First one is wrong නේ ළමයි. වැරදිනේ. හරි. පළවෙනි එක වැරදි. Target saturation should be maintained over 94% in all patients. That's like a වැරදි. කතන්දරේ සම්පූර්ණයෙන් වැරදි. I told you that patients with COPD commonly have chronic CO2 retention. නේ මතකයිනේ කිව්වා. Chronic CO2 retention තියෙනවා කියලා. And that sort of, remember I told you, it desensitizes the respiratory center. Right? That high CO2 desensitizes the respiratory center. And now the respiratory drive is maintained with hypoxia. නේ මේ patient ලගේ respiratory drive is maintained purely by hypoxia. Right? So, in patients with chronic CO2 retention, which is most of the patients with COPD, at least significant COPD, you maintain a saturation of 88 to 92%. And that is your target. So first statement is absolutely wrong. Bronchodilators, if you give these patients too much oxygen, you are removing that hypoxic drive to breathe. Right? So that is a problem. Right. Second one, bronchodilators have no role in the management. We use bronchodilators. Ipratropium, salbutamol. Kahari. Easy one. A loading dose of aminophylline should be prescribed. Again, in COPD, we don't use aminophylline regularly. Right? If you can't, the patient's not responding to your steroids, nebulizers, you can consider it, but it is not recommended. Should be prescribed. Again, because the same reasons of toxicity. Now, the next one is a rather controversial statement. Antibiotics should be given even in the absence of symptoms and signs of infection. Right? That is actually wrong. Currently, a guideline එකක් කියවුවොත් ඒක කියන්නේ මොකද හැම වෙලෙම ඔය guideline එක විදිහට තමයි උත්තරේ ගහන්න ඕනේ in the exam. The guideline will say give antibiotics only if there is evidence of infection. නිකන් ඔහේ දෙන්නේ නැහැ because of the risk of resistance නේ antibiotic resistance. ලංකාවේ නම් ඒව කරන්නේ නැහැ නිකන් COPD දැක ගමන් coamoxiclav වරි මොකක් හරි දෙනවා. හරි? But the guideline will tell you no, look for at least cough, sputum මේ වගේ තියෙන කෙනෙක්ගේ විතරයි antibiotic දෙන්නේ. Right. Right. So how do we treat COPD exacerbations? The oxygen should be controlled. Remember, in patients with CO2 retention, bronchodilators, steroids, and antibiotics if the patient has infection. There is no place for use of magnesium sulfate in COPD. Long proper appointment you watch for about 1 hour with this treatment. 1 hour. If the patient is getting exhausted or the patient develops type 2 respiratory failure, what do? Type 2 respiratory failure. Then you have to give them NIV. And the mode that we use is BiPAP. Recommended mode. So if they are getting exhausted or if they are developing type 2 respiratory failure, then give them NIV. Okay. Any questions about that one? So ඔක්කොම ටික අපි හරි නේද මේක වැරදි. හරි. Fine. So this best response MCQ is also linked to that previous discussion that we just had. So make this patient has type 2 respiratory failure. Sorry. Make උත්තරේ මොකක්ද? හරි. So BiPAP. හැබැයි මෙතන පොඩි සමහර වෙලාවට මේක පොඩ්ඩක් වෙනස් කරලා දෙනවා පරිස්සමින් බලාගෙන කතන්දරේ දෙනවා patient whatever home patient is on 100% oxygen or something කියලා දීලා ඊට පස්සේ දෙනවා type 2 respiratory failure කතාවක්. එතකොට මොකද කරන්නේ? දැන් මෙතන එක කියලා නැහැ. ඒ නිසා we assume that the patient is on the proper oxygen. But සමහර වෙලාවට දෙනවා this patient is on 100% oxygen මේ හරි මොකක් හරි then ඕක දෙනවා මේ කතන්දරේ. හරි? Then the answer is to reduce the oxygen because what is happening is the oxygen is depressing the respiration causing CO2 accumulation. හරි? ඒ වගේ ලෙඩුන්ගේ O2 එක චුට්ටක් වැඩි වගේ තමයි දෙන්නේ. ඒ වගේ statements උත් අපිට හදන්න පුළුවන් ලේසියෙන්. So හොඳ high oxygen එකක් දෙන patient කෙනෙක්ගේ CO2 retention impending type 2 respiratory, that sort of story, what you do is you turn off the oxygen, right? Or reduce the oxygen, reduce the oxygen and see if there is any improvement. Because what's happening is the hypoxemia drive is knocked off, causing carbon dioxide retention. Hari? Patient husma ganna naha. Eka පොඩ්ඩක් පරිස්සමෙන් බලන්න ඕන දෙයක්. Right. Okay. Any questions about this one? ළමයි? Normal ranges දෙනවා බය වෙන්න එපා. kilopascal හරි millimeters mercury මොකක් හරි දෙන එකක you will get the normal ranges, so don't worry. Hi. Right. Okay. Now in the long case in the prof appointment we talked about how you would sort of assess and manage a patient with COPD. මතක ඇති නේද? So you have to confirm the diagnosis first, right? And you have to ideally do a post bronchodilator FEV1 FVC. Post bronchodilator FEV1 FVC. So remember we talked about the reversibility criteria neda? 12% rise in FEV1 FVC or 200 ml rise in FEV1. Q1 asthma wala kiyanakota. So COPD obviously doesn't meet that criteria and the FEV1 FVC ratio is less than 0.7. Right. And then you have to, after you make that diagnosis, you have to assess the degree of airflow limitation, and that is by the GOLD classification. Then, remember I told you that using two key parameters, we put the patient into one of four groups. Right. What are the two key parameters now? Number one, assessment of symptoms, right? Degree of symptoms. Assessment of degree of symptoms is one of them. ඒකට අපි පාවිච්චි කරනවා MMRC classification and CAT කියලා scoring systems දෙකක්. Right? From that, we can assess their degree and impact of symptoms. කොච්චර දරුණුද බරපතලද මේ symptoms කියන එක. So that's with the MMRC and the CAT. The other feature is we assess their exacerbation, risk and severity. කොච්චර exacerbations තියෙනවද මේ patient කියන එක. Exacerbation, risk and severity. So we assess their symptoms, their impact of symptoms and their exacerbation, risk and severity. And from that you can divide them into four groups, A, B, C, D කියලා හතරකට බෙදෙනවා. And then the initial therapy lamai is decided based on what category they fall into. Now the problem is මේක හැම අවුරුද්දෙම වෙනස් කරනවා. ආයි පොඩ්ඩක් වෙනස් කරන්න හදනවා, but I don't think it will be implemented anytime soon. Yes, I know. Answer ඕක අහනවා අනිවාර්යෙන්. I know that you, but don't worry, that will not feature in your exam. ඒකයි මම ඒක කිව්වේ නැත්තේ. Because it's a 2023 update to this bloody thing, and they have changed it again, and there are only 3 groups now. If you want, I can send that to you. But ඒක විභාගෙට දෙන්නේ නැහැ. මොකද ඔයගොල්ලෝ ප්‍රශ්න ටික හැදුවේ ගිය අවුරුද්දේ. ඒ නිසා විභාගෙට දෙන්නේ නැහැ. ඒකයි මම පරණ එකම තාම කියන්නේ. හරිද? But yes, there is another update. මල වදයක් හැම අවුරුද්දෙම ඕක වෙනස් කරනවා. දැන් A, B, E කියලා 3යි තියෙන්නේ. right? Nonsense. So essentially, forget about that answer. ඒක දැන් ඔයගොල්ලෝ විභාගෙට දෙන්නේ නැහැ. ඒක we stick to this relatively old one. හරි. So based on the ABCD, you can see this මෙන්න මේ වගුවේ මොනවද දෙන බෙහෙත් ටික තියෙනවා කියලා ඒකේ තියෙනවා. So you have to remember this, right? ඒක මතක තියාගන්න. And පොඩි point එකක් මට මෙතන කියන්න ඕන දෙයකට තියෙන්නේ yes මේ the role of inhaled corticosteroids දැන් asthma වල හොගාලා දෙනවා නේ. But in COPD they are limited to people who have exacerbations and a high eosinophil count of more than 300. Hari? So steroids පාවිච්චි කරන්නේ in COPD if they have a eosinophil count high, if they have exacerbations, or they have overlap with asthma. සමහරවිට asthma COPD overlap එකක් වෙන වෙලාවල් තියෙනවා. So those are the 3 instances where we use steroids now in COPD. ICS පාවිච්චි කරන වෙලාවල් ඒ කිව්වේ. So exacerbations තියෙන්න ඕනේ, right? They should have a eosinophil count. Usually 300 තමයි threshold එක, right? But 150 300 අතරත් දෙන්න පුළුවන් කියලා කියනවා. But ඒව ඔයගොල්ලෝගෙන් අහන්නේ නැහැ. Eosinophil count එක වැඩි වෙන්න ඕනේ. And also asthma COPD overlaps තියනකොට දෙනවා. හරි? Okay. And then of course once you initiate therapy, you add on inhalers as you go. And again, we stick to those 2 features. Dyspnea නම් main problem එක යන්නේ එක විදිහකට, exacerbations නම් main problem එක යන්නේ තව විදිහකට. හරි? But ඒවා ඔයගොල්ලෝගෙන් details අහන්නේ නැහැ. Right? Details අහන්න නිසා බය වෙන්න එපා. But අර steroid කතන්දරේ චුට්ටක් මතක තියාගන්න. ඒක අහන්න පුළුවන්. ඒක හැමෝටම දෙන්නේ නැහැ කියන එක තමයි. That is the one you should remember. It's not given to everybody now. Right? There is a special risk of exacerbation, eosinophil count, and the asthma COPD overlap, all considered in these decisions. Right, good. All right, okay. Right, now a few more things to talk about. Regarding the management of COPD, cessation, say stopping of smoking, reduces the progression of the disease. Right, cessation of smoking reduces the progression. That is correct. Right. In COPD long-term management, probably the only thing that has a mortality benefit is long-term oxygen therapy. Right? Probably the only thing that has a mortality benefit is long-term oxygen therapy, survival benefit. Right? Some people say that these long-acting muscarinic, LAMAs, have some mortality benefit, but strong evidence again. But long-term oxygen therapy definitely, yes, improves survival. එතකොට ඒක මෙතන තියෙනවා මෙන්න මේ long term oxygen therapy, there is a strict definition to use it. මෙතන ඒක තියෙනවා, මේක කවදාකවත් ඔයගොල්ලෝගෙන් අහන්නේ නැහැ, just for you to look at. හරි? PO2 එක යම්කිසි ගාණක් වෙන්න ඕනේ, right? Or they can have heart failure, right? Heart failure. So there has to be a specific criteria for giving it. And you have to give for at least 15 hours a day. Right? And it is probably the only therapy that improves the outcome. Probably the only therapy that improves the outcome. At least, I mean, දෙන්න ඕනේ පැය 15කට වැඩිය දෙන්න ඕනේ දවසකට දෙනවා නම් 15 hours a day at least. හරි. ඒක හරි. So use of inhaled long-term bronchodilator had mortality benefit, බොරු කතාවක්. That's wrong. Inhaled steroids have better efficacy in patients with eosinophilia. Yes, eosinophilia වෙන්න ඕනේ නෑ හැබැයි. 300ට වැඩි වුණත් ඇති. And in certain situations between 100 to 300 also you can give it. So remember, steroids then eosinophil count threshold, asthma COPD overlap patients, plus patients who have recurrent excesses. These are the people where we use the steroids. And in a very small group of patients who have recurrent exacerbations, you can use azithromycin. Right. So we're going back to the question on mild, moderate, severe exacerbations. No, that doesn't really change the management. You do that for all these for everybody really. Cancer lung volume reduction model, that I don't know. Product right? As far as I know, it doesn't, but I will check that. Right? Right. Okay, right. So that is all about COPD, Lamai. All the questions related to COPD. Right? So exacerbation management, long-term management, etika. And yes, the guideline has changed again, but stick to this for your exam. Right?
So does azithromycin have a effect on disease progression as well?
Again, it's slightly controversial, but there's an anti-inflammatory effect also. So people say that there might be some modification in the airways or something like that, because it's an anti-inflammatory drug as well, apart from its antibiotic effect. Antibiotic effect.
But a mortality benefit
no clear proven benefit no. Right, there are studies but this doesn't reach that firm evidence level. Long-term oxygen clearly, there is no doubt about that. Right? Right, good. Yes, recurrent exacerbations තියෙනවා නම් තමයි දෙන්නේ. හරි? Okay. Right. Next one is on interstitial lung disease. Now, this is a very complicated classification of interstitial lung disease. And you're not supposed to know this, so don't worry. Right? And මම එක ටිකක් කියලා දුන්න ඕගොල්ලන්ට that there are idiopathic, various types of idiopathic interstitial lung diseases. Right? Autoimmune or connective tissue disease related ILDs. Hypersensitivity pneumonitis related ILDs, right? That is sort of farmer's lung, that sort of thing. Sarcoidosis is a granulomatous disorder that can cause ILDs. And there are a whole lot of drug-induced and other rare people which nobody is really worried about. Right. You don't need to know this, don't worry. What you need to know is possibly, right. So let's go through these. Can occur due to exposure to asbestos is true. So it's occupation related ILD. ඔය වගේ වෙනත් occupational exposures ගත්තොත් silicosis is one of them. Beryllium exposure is another one of them. Radioactive plants where people get exposed to beryllium. So beryllium is another one. Asbestos is one. Silica is another one. Right. Idiopathic pulmonary fibrosis is a type of ILD which is included under the group of idiopathic. There are others also, as you can see. Right? And clubbing is a feature. Right. ILDs typically present with progressive shortness of breath. We discussed during our long cases. And they can have dry cough. Copious sputum production is not a feature. These patients present with dry cough. Dry cough. All right. Then I told you when you're establishing a diagnosis of ILD, you have the clinical syndrome, right? And the cause on one side. But then you have to do a lung function test. And the lung function test is a restrictive pattern that you get clearly. And because of the alveolar capillary membrane, the fibrosis occurring in the alveolar capillary membrane and the sort of interstitial compartment of the lung, the gas diffusion is affected. Reduction in DLCO is a feature then. DLCO එක අඩු වෙනවා. DLCO එක අඩු වෙනවා. So they have a restrictive pattern in lung function test plus a reduced DLCO because the gas diffusion is affected. And then, so clinical, history exam, causes, etica, then your DLCO lung function test. Then the next thing is the CT scan. So you have to do a high resolution CT scan, which you need to do. And in some selected cases, not in everybody, a lung biopsy might be needed. Selected. Hamogema නෙවෙයි. It is a selected group of people where we do a lung biopsy. So selected නිසා so copious period වැරදි, reduction DSO හරි, lung biopsy in all patients කියන එක බොරු කතාවක්. හරි. ඒක වැරදි. Right. Right. So this is what a typical scan looks like. This is called honeycombing. Mechanical honeycombing. And you can see bronchial dilatation method, right? That's called traction bronchiectasis. Traction bronchiectasis, and X-ray has no place in ILD diagnosis, right? You have to do a high resolution CT scan. මේක ඔයගොල්ලෝ නිකන් පාඩම් කරගන්න ලොකුවට අවශ්‍ය නැහැ. ඔය මේ there are all these various ILDs. Some affect the upper lobe predominantly. Some affect the lower lobe predominantly. This table gives you a list of that, right? But especially hypersensitivity pneumonitis, ankylosing spondylitis, sarcoidosis affect the upper lobes, right? Upper lobes affect them. Idiopathic keva godak lower lobes. Idiopathic ka loku idiopathic set එකක් තියෙන ගොඩක් ඒවා lower lobes. හරි? Just remember one or two of those in the later MCQ එක ඇහුවොත් එහෙම. Right. Okay. Any questions about this? ILD ගැන මොන හරි ප්‍රශ්න වැඩි MCQ අහන එක area එකක් නෙවෙයි යෝක එකක් ඕනනම් දෙන්න පුළුවන්. හරි? It's a complicated area.
So when you said that causes traction bronchiectasis, in the sense that ILD can cause bronchiectasis as well? No.
So that is a thing. Traction bronchiectasis is completely different from actual bronchiectasis. A traction bronchiectasis because the peripheral tissue is shrinking, it's just pulling the airways apart. There is nothing to do with the actual bronchiectasis. So it's a venous.
Thank you.
Yeah.
Sir, this upper zone, lower zone කියලා ඔය අර බෙදලා තියෙන clinically අපිට කියන්න පුළුවන් වෙන්න ඕනේ.
Amarui, very difficult, right? This is all on CT scans, right? So it's very difficult. When ගොඩක් වෙලාවට lower zone involvement is very common. There are only a few that affect the upper lobes, yeah?
Right, thank you.
Yeah. But this is all on CT scans, very difficult to take on clinical examination. Right. Right. The best response MCQ here is very typical of systemic sclerosis related ILD. Right, so interstitial lung disease is the answer here. Secondary to systemic, so it's an autoimmune or connective tissue disease related ILD. Hari. And then there is a SCQ on COPD which you have to do. Hari. Okay. උත්තර වගේක් තියෙනවා ඒවා බලලා ලියන්න හැම එකම ලියන්න because I don't want you to fall into the same situation as the last year's fellows. Even though they did very well, there are lots of people who could have passed if they had done better in the SCQ. So please don't neglect the SCQs. ඒ ටික කරන්න. But I don't have time to discuss everything. We'll do a few a day. හරි 4-5 විතර කරමු just as an example of how to write answers. Okay, right. හරි. So that is that for the day. Right.
Sir, quick question. So in that last SPR, how did you rule out pulmonary edema?
In the last?
In just the last SPR where you took it as ILD.
Oh, pulmonary edema, the whole story is, you take this history of the systemic sclerosis, everything together, it's more likely to be ILD. Best response, but the physical signs I agree can be, can have an effect.
Right, thank you.
Yeah, so thank you for sharing this. Somebody sent me a evidence-based summary. Yes, there are some other therapies that are shown to have a mortality benefit. Lung volume reduction surgery එක තියෙනවා නේද? Yeah. Yeah. So that's fine. හැබැයි මේක බලනකොට පොඩ්ඩක් බලන්න කොච්චර RCTs it's a different way of assessing these sort of things, right? Of all of these, LTOT is the strongest evidence, but there are some other ones that also have been shown to have certain degree of benefit. Yeah. Okay. Thank you. Yes. Okay. Right. Right. Any questions? Janni ප්‍රශ්නයක් අහන්න තියෙනවද? Okay. Right. Okay. So චමත් ආයි කවද්ද පුළුවන්ද සතිය දවසක් පුළුවන්ද ආයි කරන්න?
පුළුවන් සවලක් නැහැ.
මම හෙට කියන්නද?
හරි සර්.
හරි. ගොඩක් අය Thursday වගේ තමයි යා.
Okay. Then it's okay. Okay. Thank you, sir.
Okay. Right.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.
Thank you, sir.